LCL. You're going to look for the tibia to move away from the femur when you're doing this. So you're just going to have the patient extend the knee, and then you're going to apply varus valgus pressure. So you're going that way, and this is testing the MCL, and then you're going to go opposite, and that's testing the LCL for the varus. That's pretty much.
Yeah, and you can do it in different, she's doing it in, I'd say, what, about 30 degrees of flexion. You can do it, once you get into there, you're not, the ligament's too slack to really be able to test it. You can also do it in full extension like that. And then, like I said, you may end up, if you're talking about somebody with a big knee, you know, you may need to get better angle like that, so you're actually pushing here, so that your line of drive on this hand is perpendicular to the joint, or to the long axis of the bone. And then on the other side, well, I'll just do this side here. So again, you're gonna, this will give you more leverage than, you know, the way she's doing it here, which is fine. And if it's, unless you're talking about somebody, some big football player with a big, huge leg, right? You're gonna need to get more of an angle like that. Okay. So once you can just describe it.
So this is called the Fairbanks apprehension test, or patellar apprehension test. And you're just checking to see if the patella has been dislocated. So you're going to have your patient supine. They're going to flex their knee here to about 30 degrees, maybe about there. And then you're going to apply, go ahead and relax though, just stay relaxed. It's really important that they're very relaxed. And you're going to apply lateral pressure and to the patella here. And apprehension in this case would mean that their quads would tighten up so that you wouldn't be able to push the patella laterally, and it would go medial and protect the dislocation from happening again. So again, all it is just a lateral translation of the kneecap. And you're waiting to see them flinch and tighten up the quads to keep it from going lateral.
Usually I've seen it done with the knee extended like that.
Okay.
And then you know, you can do it on the side with the hole in the pants, right? So you can see the kneecap.
That's true. So just lateral translation of the kneecap.
But just like in a lot of the knee tests, you can do it in different amounts of knee flexion. But I think usually, I think the way it's in the book and other ways I've seen it is with the knee like that. Because you can see that there's more slack into the knee. And then in that position, I mean in the patella, you can move it more readily versus if it's up like this. But again, that's valid as well. Okay. Okay?
Thanks.
So in case you didn't notice, there's a hand.
Are there more? Yeah, no.
More handouts?
Okay.
If anybody didn't get one, we didn't have one for the valgus and varus, but we've got one for the apprehension and the drawer.
Yeah, I know.
Okay, so next one is the anterior drawer test, and we're testing for ACL laxity. So what we're going to do is we're going to have her flex the hip at 45 degrees and the knee almost 90 degrees. And you want them to be relaxed. And you're going to have a firm grip at the proximal tibia and have a gentle to and fro motion. And so you're going to start off first with the unaffected leg, so you can compare the two results. So there should be.
One other thing is that if you internally rotate the tibia, what it does is it twists the cruciates, so it should be more tight when you do that. So try it again and see if you notice a difference if there's laxity of the knee joint. If you try the two different positions, usually when you internally rotate it and you see that it's taken up some of the slack, then you know that that the ligament's there, it's intact, that it's made a change by turning it in. Okay, so now let's look at what happens when it's not red. What did I mention before about some specific things you're going to ask about knee? What's that? Yeah, I mean, that's when you get asked in a general thing, but something specific that for knee problems, like if you ask, does your knee ever lock up or give way, things like that, to try to identify in your mind, is there going to be any potential of meniscus problems or ligament tears? You know, obviously if they say that their knee, the joint was moving around kind of sloppy like you saw in that video there, you're going to know that there's some laxity issues and things like that. So again, then there's all this standard types of things. Mechanisms of injury, how did it happen? Any previous injury, like you said, type of pain, what makes it better, what makes it worse, all your standard stuff. And then observation, you're going to look at the curvatures of the knee, if they're full-legged or knock-kneed. And then also from the side, look for genu recurvatus, when if their knee is hyperextending. You look at the position of the patella, if it's what they call Baja or Alta. And then, you know, here you're looking for if the legs are turned in like that. And then there's the Q angle. I mean, obviously, females tend to have more of the patellofemoral tracking problems because the pelvis is a little bit wider, so that the femur comes in at more of an angle. And then you've got the Jeff Foxworthy knees, right? Okay. So then, like I said, you look at the position of the patella, or if the knee is hyperextended. And this is one of the things that I added in. It's not in your notes, but it's on that little handout sheet. There's a few different things, and we'll talk about it in the ankle as well. These are the types of things where they've done studies in emergency rooms, and they try to identify what is the indication is when somebody needs to have an x-ray. So in a knee situation, if they have a blunt trauma or a mechanism of injury, or a blunt trauma or a fall, and then some of the following mechanism of injury, somebody younger than 12 years or older than 50, inability to walk, 4 weight-bearing steps. So those are indications that there's a higher degree of a fracture. And we'll talk about similar types of things in the ankle. So again, these are types of things when we talked before about like a red flag. You know, when is this something that you're going to need to maybe have an orthopedic look at it or have an x-ray? So range of motion, these are the normal flexion 135, extension is usually it's going to be neutral, but some people will have some hyperextension. Internal and external rotation, again, you're only going to see that when the knee's flexed. And then actually using the inclinometers, goniometers. In a situation like this, it's almost easier just to go ahead and use the goniometers. And basically you're putting it at the fulcrum is going to be at the lateral aspect of the knee, at the lateral epicondyle here. And then this is going to go up the long axis of the femur. And what would be a good thing to point it at up here? Okay. And then what would be a good thing to point at down here? Okay. So then you just flex the knee. And like I say, extension is going to be neutral, and you know maybe you might have some hyperextension. You're not going to measure internal, external rotation. And then palpation. These would be the tibial plateaus. And then this is the joint line. Like I say, if you look for what we call the eyes of the knee, where if you go down from the patella, it's like there's 2 little indentations right there. Now it's going to be at the joint line. So that's where you're going to check for the meniscus. And then the patellar tendon, the patella. You know, you get back to the backside of the gastrocnemius, and then you can palpate the more superficial ligaments, the collaterals. And when you're palpating along the joint line, you can get to the point where you actually can feel the edge of the medial collateral ligament. You'll feel that here you can go in there, and then all of a sudden you get to a point where you can feel the fibers of the medial collateral. And then checking the quadriceps. And then you can also check for atrophy again, specifically like here at the VMO. You know, if somebody's had a knee injury where they have some kind of swelling or locking where they're not able to extend their knee, and over time they're going to start developing some atrophy in that